struggling to make ends meet, and countless small businesses are forced to close their doors permanently. More than 4 million Americans getting immunized every day, and the number of deaths from coronavirus are declining. So there is indeed light at the end of the tunnel. But we're not out of the darkness yet, and I'm concerned that as cases continue to rise, particularly in my home state of Michigan right now, that vaccines are certainly an important step to prevent the spread of COVID-19, but we still need to practice social distancing, wear a mask, and follow the advice of public health experts to get this resurgence of the virus under control, especially as variants continue to spread all across our country. Tragically, it didn't have to be this way. The lives lost, the permanent changes to people's personal health, the economic devastation, and the long months of personal sacrifice and suffering were not inevitable. Adherence to years of pandemic planning by prior administrations, decisive action, clear leadership from the Trump administration could have helped mitigate this pandemic. In fact, since the first whole of government pandemic response plan was published in 2005, the United States had ample opportunity to prepare for this type of public health crisis. Professionals across our government spent years working to improve our pandemic preparedness, from a pandemic response playbook drafted by the National Security Council in 2016 to a 2019 Department of Health and Human Services series of exercise called Crimson Contagion that simulated a highly contagious airborne influenza pandemic. In 2019, I conducted an investigation and released a report that identified the serious national security risk posed by our over-reliance on foreign manufacturers for critical drugs and medical supplies. My report found the United States was unprepared to deliver vaccinations on the scale needed during a pandemic and made critical recommendations that could help onshore manufacturing for essential supplies. Unfortunately, despite preemptive actions and warnings, the previous administration failed to take necessary steps that would have limited the impact of this coronavirus pandemic. Instead of acting swiftly and decisively, the previous administration chose to sideline our nation's foremost medical experts and failed to implement a comprehensive national strategy that left individual states to combat the virus all on their own. In fact, we know President Trump was aware of the virus, that it was both deadly and contagious as early as February 2020. However, he continued to tell the American people it would, quote, miraculously disappear, end of quote. And initially even compared the effects to the common flu, when scientific evidence clearly showed that coronavirus was much more lethal. At a time when the administration could have provided clear and consistent communication, supported scientific guidance on needed public health measures, and ramped up production of PPE and other critical medical supplies through emergency contracts and fully invoking the Defense Production Act, among other critical actions, the previous administration sought to rather downplay the virus severity to the public. On top of those failures, there have been numerous reports of widespread political interference in federal agencies' COVID-19 response, including reports that the Health and Human Services political appointees reviewed and may have altered or delayed weekly scientific reports issued by the Centers for Disease Control and Prevention about the pandemic. The Trump administration's inactions and efforts to minimize the threat posed by COVID-19 contributed to the carnage our communities have seen over the past year. Despite representing only 4% of the world's population, by January of 2021, the United States accounted for nearly a quarter of the global COVID-19 cases. There's no question that the federal government must learn from these missteps and urgently work to strengthen our pandemic response to ensure that we can both combat the ongoing pandemic and prevent the next crisis, whenever it may be, from reaching the magnitude we have seen with this one. Today, we will hear from former officials from key agencies in the federal government, all of whom are widely credited experts in their respective public health and emergency preparedness fields. I look forward to a very frank and open discussion and clear and candid recommendations about what we must do to prevent past mistakes from moving forward. It is our duty to ensure that our nation is better able to meet whatever the next crisis may be. With that, I turn it over to Ranking Member Portman.
Thank you, Mr. Chairman. I appreciate the fact that our oversight so far, and we have sent a lot of letters and done a lot of interviews, that oversight has been not just bipartisan, but nonpartisan, and that we have been able to set aside politics and focus on the facts and past events, but also on the road ahead of us, and how we can learn from what happened during this unprecedented, tragic coronavirus situation. First, though, I want to take a moment to acknowledge the extraordinary loss that our nation has experienced. As of this morning, 559,741 Americans have died because of COVID-19. And like just about all Americans, I've lost friends. I've also lost former staff members, and we all join with the families in grieving those we have lost during this pandemic. I also want to express my gratitude for the work and the sacrifice of those who have been on the front lines, particularly those healthcare professionals who have been out there on the front lines for all of us, 1,541 of whom died fighting this pandemic. So COVID-19 has been catastrophic. There's no mistake about that. It also presented an unprecedented challenge to, and in many ways, an unprepared U.S. public health system. Why were we unprepared is one of the questions we'll get into today. Unlike emergencies more localized in nature, a pandemic is not a singular event. COVID-19 has stretched across our entire country, in fact, the entire globe, with no regard for borders or beliefs. The scope is unprecedented. It has stressed our supply and healthcare systems, including our critical frontline personnel, as we said, and stressed it often to a breaking point. And we have seen the economic damage. Millions have lost their jobs as a result of pandemic restrictions. We're here today to understand some important issues. The United States preparedness and initial efforts leading into the COVID-19 pandemic, the initial federal response, and to identify recommendations to improve federal preparedness for future pandemics and other public health threats. We owe it to those Americans who did die as a result of COVID-19, to their families and countless others who are struggling to make ends meet, to make this a serious, nonpartisan oversight effort. Looking at the steps the federal government took in the initial days of the pandemic, we got to learn from the experience for the future. To that end, I think there are three issues important to address. First, CDC surveillance systems and the lack of testing limited our early response. We know that China irresponsibly downplayed the initial severity of COVID-19. In my view, there's no question about that. That presents questions about our ability to work with global partners, particularly China, to identify and combat pandemics in their nascent stages. But how did we do in the United States at recognizing and communicating COVID-19 cases, symptoms, and deaths once the pandemic reached our shores? The CDC can only communicate and address the issues it knows about and understands. In many instances, what we found out is that COVID-19 cases manifested in patient symptoms and were ultimately the cause of death. That information was slow to reach the CDC. Why was that? Instead of seeing real-time data, CDC was only seeing fragmented historical data. Adding to surveillance challenges, diagnostic testing was slow to develop and then slow to scale up to the level required by the pandemic. Why was that? It's critical that we enable state and local public health officials to communicate effectively and directly to the CDC. We also must have the capability to scale up testing when needed. We know those things. We've got to talk about how we can do that better. In a future pandemic, this could mean the difference between quick life-saving decisions or confusion and the needless loss of life. Second, who was in charge? Where was the accountability? This is something I look forward to asking some of our distinguished panel about today. because they've had a lot of experience in how these things are managed. A recurring narrative in interviews with former government officials, like the ones we have today, and public health professionals, is that in the initial stages of the pandemic, leadership roles were not well defined. And they still are not well defined, in my view, in some respects. This resulted in confusion at the federal, state, and the local level, and likely slowed our initial response considerably. But we knew this was going to be an issue. In 2019, HHS ran an influenza pandemic tabletop exercise called Crimson Contagion. That exercise identified the lack of defined leadership as a major challenge. The exercise found that insufficient and conflicting statutory authorities defining leadership roles hampered the federal government's ability to effectively respond to a pandemic. Confusion about leadership was also an issue identified following the 2009-2010 H1N1 pandemic. So this should be a cautionary tale for us as we continue our review. It's not enough to identify issues. We've got to be forward thinking and actually implement solutions to the issues we discover. Third, this unprecedented pandemic crippled the U.S. medical supply chain in the initial weeks of the pandemic. Why was that? It was due in large part to the longstanding over-reliance on China for pharmaceuticals and other medical supplies, including PPE. Reports indicate that China, as early as December 2019, increased imports and decreased exports of medical supplies as their own needs increased, dramatically shrinking U.S. purchasing ability. Compounding this issue was the lack of an organic medical supply stockpile here in our country. The Strategic National Stockpile, SNS, which we'll talk about a lot today, the largest federal repository of pharmaceuticals and critical metal supplies available for rapid delivery to support the response to a public health emergency, was not adequate when those state and local supplies are depleted. And it was frankly understocked. We need to talk about why, and again, how to prepare for the future. The SNS was never replenished despite urgent requests after the 2009 H1N1 pandemic, and further, it was never meant for a nationwide response. This too was an issue we knew about. Past pandemic exercises and lessons learned from prior pandemics, such as H1N1, told us that the supply chain resiliency was an issue. Now let's consider this: a critical supply chain with a single point of failure, a strategic national stockpile that was never meant for a national response. I understand the supply chain has mostly recovered and the stockpile is restocking, but we can't allow these issues to impede a further pandemic response. So the tragic loss of life, the devastating impacts on the economy and American workers, and also the destabilizing effect on global stability and security has taken a toll on all of us and all nations. Given the extent of existing issues within the public health system I just discussed, it's little surprised that the initial pandemic response was chaotic and unorganized. Again, Mr. Chairman, I appreciate the nonpartisan nature of this review so far, and I stress the importance of identifying a bipartisan way forward. We've got to figure out how to come together, learn from these lessons, and be better prepared next time. I thank our witnesses for being here today. I look forward to hearing from them and look forward to hearing on their thoughts on the way forward. Thank you.
Well, thank you, Ranking Member Portman, for your opening comments. And I, too, look forward to working closely with you and every member of this committee to find answers to the questions that we have and then put forward meaningful solutions and action plans. So I look forward to that work. It is the practice of the Homeland Security and Governmental Affairs Committee to swear in witnesses. So if each of you who will be testifying, I know you're on video, but if you wouldn't mind standing and raising your right hand, I would appreciate it at this time. You swear that the testimony you will give before this committee will be the truth, the whole truth, and nothing but the truth, so help you God. You would respond, I do, and put your take off your mute and say, I do, please.
I do.
I do. I do.
Thank you so much. You may be seated. Our first witness today is Dr. Nicole Laurie, a former Assistant Secretary for Preparedness and Response at the U.S. Department of Health and Human Services from 2009 until 2017. Dr. Laurie is currently the Strategic Advisor to the CEO and Response Lead at the Coalition for Epidemic Preparedness Innovations. And during her 8-year term as Assistant Secretary for Preparedness and Response, she led the HHS response to a number of public health emergencies, from infectious disease to natural and man-made disasters. and is responsible for many innovations in emergency preparedness and response. Dr. Lori, welcome to the committee, and you are now recognized for your 5-minute opening statement.
Great. Thank you, and good morning, Chairman Peters, Ranking Member Portman, and others. As you heard, I am Dr. Nicole Lurie. Let me just stress that today I represent only myself. The role of government is to protect its people from harms and to build resilience to those that can't be prevented. And that means preparing for the worst and scaling back when it's appropriate to do so. As we know, the US government has been preparing for a pandemic for decades. And as a country, we've developed, exercised, and refined plans, created robust authorities that have enabled nimble response systems and infrastructure. And as we know, these have been put to the test during many events which were successfully managed within existing authorities. After the West Africa Ebola epidemic, the pandemic office at NSC was reconstituted and developed a comprehensive playbook. Countermeasure development was guided through a formal coordination process known as the FEMC. But even these actions, and that process was significantly degraded. But even these actions can't fully explain the failure to act when we were first alerted to a potential pandemic. And I want to peg that at the end of December 2019. We lost a month of valuable time between then and when a public health emergency was declared. In part, I believe that a climate of fear and retribution had developed over the years leading up to the pandemic, and that this inhibited seasoned career employees and key agencies from stepping up and speaking out. You've asked whether or not the authorities for a successful response were sufficient, and I believe the answer is generally yes. But all the authorities in the world cannot make up for the failure of leadership and its devastating outcomes. Here are 10 things I think should have happened early on. As soon as hearing about the outbreak in China, the administration should have played out the likely scenarios, making a plan for each. Communicating from the top in a clear, forthright, and consistent way about the severity of the threat and what to do about it. Developing and executing a real-time research agenda. Strengthening surveillance and testing. The failure of test development at CDC and the inability of state and local health departments to deal with testing and tracing is well known, but the authorities to develop and scale testing were not leveraged, and public health and healthcare data remain largely unlinked, with signals of the staggering racial and ethnic inequalities going unaddressed for way too long. Examining what was in the SNS. It was always clear there was not enough PPE, but emergency contracts to ramp up production in early January and to gain visibility into the supply chain should have been executed. Recognizing and addressing the other health-related supply chain vulnerabilities predicted from the get-go. Putting the healthcare system on alert so it could prepare the staff, supplies, policies, and for community-wide coordination. Starting countermeasure development early as soon as the threat was detected to include diagnostics, therapeutics, and vaccines. NIAID jump-started work on an mRNA vaccine, but BARDA was hamstrung in taking early action. While Operation Warp Speed came together and did a phenomenal job with vaccine development, it couldn't make up for lost time, especially with regard to diagnostics and therapeutics. As a point of reference, CEPI, where I work, was worried enough about an impending pandemic that its staff activated vaccine developers in early January, even before the sequence was posted. It could always take an off-ramp, but not make up for lost time. Coordinating across all levels of government and providing guidance for healthcare settings so people weren't left to fend for themselves and compete with one another, and mobilizing private sector partners. So I appreciate the opportunity to look forward. Here are a few things that I think we need to do. First, I think we need to make it safer for career employees to do their jobs, including maintaining the integrity of our science agencies. Second, reconceptualize the organization and role for public health. America needs a modern public health system, not just at CDC, but across the country. Third, maintain a standing emergent infectious disease fund at BARDA. 4, re-examine the SNS, what it's for, ensure it can be activated for surge production on demand, and has responsibility for monitoring and addressing critical supply chains going forward. Strengthen and clarify selected authorities at FDA. And I'll say 6, protect against cyber threats to our research, our manufacturing, our supply chains, and our public. It's important to remember that preparedness requires continuous, proactive financial investment. It's all too easy to lose sight of the fact that preparedness is forever. We can't afford to let our guard down. Almost 600,000 dead and still counting. We can't make up for lost time or lost lives, but we can act on the hard lessons learned. Preparedness and response have always been bipartisan or nonpartisan, and I appreciate the spirit in which this hearing is being held. Thank you.
Well, thank you, Dr. Laurie, for your opening comments. Our second witness is Dr. Julie Gerberding, a former director of the Centers for Disease Control and Prevention at HHS from 2002 to 2009. Dr. Gerberding is currently the Executive Vice President and Chief Patient Officer at Merck & Company. She also co-chairs the Center for Strategic and International Studies Commission on Strengthening America's Health Security. While at CDC, Dr. Gerberding led the agency through more than 40 emergency responses to public health crises. She has been recognized for her leadership in responses to anthrax, bioterrorism, and the September 11th, 2001 attacks. Welcome, Dr. Gerberding, and you may proceed now with your 5-minute opening statement.
Thank you so much. Chairman Peters, Ranking Member Portman, and all the members of the committee. It is an opportunity to appear today and do whatever I can do to contribute to improving upon the lessons that we've learned. Unfortunately, we cannot expect this pandemic to be an isolated event, and what we can do now will help improve our overall preparedness and response for this crisis, but also for whatever is in store for us in the future. We're in the middle of a war right now, and it's too soon to declare victory. Well, I'm sure we will eventually prevail. We're dealing with, on one side, the virus, which continues to spread and cause severe disease in new populations and certainly new countries and new regions. We are dealing with variants, 15 so far, that are of some degree of concern, and one of which, the B.1.1.7 variant, which is now the dominant transmitted virus in the United States. But we're also dealing with vulnerability, a population of people that is increasingly vulnerable, not just to the impacts of this virus, but also the disruption in our social system, our care system, and the experiences that they have with the difficulties in sustaining the care and treatment for their other underlying medical conditions. On the good side, we have the vaccines, which I think have exceeded everyone's expectations. We have a lot more to learn about them, the safety, the long-term durability of their protection. And I won't be surprised if down the road we'll need a 2.0 or 3.0 vaccine armamentarium. But at the very least, this is an incredibly powerful tool, and we need to make sure that we can deploy it to all the people who need vaccination. We also have vigilance. And I know this is a controversial topic, but we've seen around the world that vigilance really can contain this pandemic without vaccine. So we need to ask our citizens to continue to contribute that part of the equation until such time that we really do have vaccine-induced immunoprotection. In my written testimony, I tried to summarize the critical requirements for success, the lessons that we've learned so far, and some of the action items that I think we could be taking right now that would strengthen our position. I won't review all of those, of course, but I do think that in addition to the sort of interim lessons learned analysis, we need to strongly encourage a commission review of all of the complexities that this pandemic has created for us, something along the lines of the 911 commission that Dr. Phil Zelikow chaired in the past. Some of us are actually involved in supporting the planning for such a commission. I think down the road that's going to really be helpful, not just to this committee, but to our nation as we harden our biosecurity front lines and really get serious about what we need to do to protect America. So let me just talk about 4 critical areas that I see as the most important right now. First and foremost is still case detection. And while we've made incredible progress with the support of the private sector in getting all kinds of tests available, we're still missing cases. And that becomes extremely important in the construct of vaccine breakthroughs or recurrent infections in people who've been infected more than once, as we need to understand how the variants are playing into that and what really is the long-term outlook for protection. So we must continue that ability to test and look for the genomic variability. In order to do that, we need to think about how to support the front line of that effort, and that takes more than emergency funding. We really have to transition to sustainable funding models that allow our public health system to invest and develop the workforce necessary to provide these services, but also a more proactive stance going forward. And that includes funding our immunization infrastructure, the data system modernization that you've already referred to, and the ability to use more modern techniques and tools in the digital space to improve the speed and accuracy of this overall case detection phenomenon. We must also improve our care to sick people. I think we've made progress there, but we're not deploying the guidance, and the frontline workers are not necessarily using the tools that we've made available. As I said, we still need to slow transmission in communities, and we have new tools there too. Merck, for example, is hoping that we will be able to assess one of our antiviral medicines as a post-exposure prophylaxis tool, and there are others that might add to our ability to keep people out of the hospital and slow down transmission in our communities. The last piece of this, of course, is countermeasure development. I've already said the biggest lesson learned is how important our biopharmaceutical and related ecosystem has been, surprising everyone with the speed, the collaboration, and the overall volume of countermeasures that have been coming forward. But we need to focus on the deployment of those countermeasures, not just in the United States, but globally, because there is no wall tall enough to keep this virus out. And if it's being spread anywhere in the world, it presents a threat to us. We also need to think ahead, and I hate to be a harbinger of negative information, but I think we're learning our lesson at a much faster pace now about how frequently these emergencies will occur. So we have to change our doctrine of response to being much more involved in predicting where spillovers will occur, preempting those spillovers, and expanding, at least in order of magnitude, our armamentarium of countermeasures through mechanisms like CEPI, NIH, and most certainly the private sector, which I believe we've learned is absolutely critical to both the development as well as the manufacturing of these countermeasures in real time going forward. So I'll stop there and just thank you again for including me in this hearing.
Chair, I think you're on mute.
Oh, sorry about that. Thank you, Dr. Gerberding. You missed my thank you. Now that I'm off mute, thank you for your testimony and for being here today. Our third witness is Mr. Joseph Nimish, former Deputy Administrator of the Federal Emergency Management Agency at the U.S. Department of Homeland Security from 2014 to 2017. Mr. Nimish is currently a partner at Potomac Ridge Consulting. He served in the United States Coast Guard for over 33 years and retired in 2010 as a Rear Admiral. Mr. Nimish has 4 decades of experience in disaster management and response and recovery operations. Mr. Nimish, it's great to have you here today to testify. You may proceed with your 5-minute opening statement.
Good morning, Chairman Peters, Ranking Member Portman, and the members of the committee. Thank you for this opportunity to appear before you. I'm proud to have served as the Deputy Administrator from Fema and in the U.S. Coast Guard. I hope my experiences provide insights useful to your program of learning lessons from the COVID-19 response and the future preparedness of our nation. The work of the Commission on the National Response Enterprise, convened by the Business Executives for National Security, has strongly influenced my thinking about the pandemic response. I was honored to serve as a commissioner in this effort, along with a very august team of leaders from business, civil society, and government at all levels, including Senator Hassan and Senator Cassidy. The whole of society approach to this challenge made the work of the commission second to none, in my opinion, and resulted in 11 actionable recommendations for redesigning our response capabilities that I offer to the committee to look at closely. I want to start with some good news. The commission found that the components of our integrated national response capability are largely in place, but COVID-19 response exposed critical execution challenges, particularly when a crisis impacts numerous states simultaneously. I'd like to focus on two of the areas of weakness identified today. That is the exercising of our response plans and the surging of the human capital, the ability to respond to the crisis. For exercising, the lack of planning rarely causes the performance shortfall. It is usually the fact that the plan is never as good as when it was first created. Time passes, new crises deflect decision makers' attention, people in positions change, dissipating the trust between stakeholders, and the plan loses its effectiveness. The U.S. has multiple plans for the response, and Chairman, you have already indicated the exercise in 2019 called PRISM Contingent. It encountered and predicted virtually every problem experienced less than several months later during the COVID-19 response. Why were we not more ready? The Benz Commission identified weaknesses in the National Exercise Program and contributed the performance challenges we saw in responding, including the low frequency of national level exercises, the limited participant knowledge of our plans, the National Response Framework and the crisis-specific action plans, the lack of clear understanding of authorities that are dictated in multiple authorizations and HSPDs, and the delegation of the responsibility for participating in those exercises from the decision makers to their subordinates. Only frequent and continual exercising keeps plans alive, enabling updating and improvements. When we think of PRISM Contingent, there was no time to be able to improve the response from the time the exercise occurred because it occurred so late in the process. Elevating the priority placed on exercising drives more effective coordination of the plans, and it allows the entire emergency response enterprise to be aware of the plans. When we talk about surge, right now 80% of FEMA's workforce is deployed in support of national COVID-19 vaccination efforts, as well as existing disasters. The problem is that these FEMA employees have day jobs. They run the National Flood Insurance Program. They oversee the billions of dollars in grant programs. They hire the FEMA workforce. They provide the information technology that FEMA relies on. Continual deployment caused by escalating frequency and significance of disaster declarations has put unsustainable pressure on the FEMA personnel and the agency itself. I am passionate about one of the Commission's recommendations to alleviate the pressure, the creation of a true civilian expertise reserve program for disasters. Modeled after the National Guard, these CREs could activate for service in both state and federal crisis and would provide emergency managers with highly trained rapid response force of professionals, just as the National Guard does today. They would possess the skills and experience contemporary emergencies require. Data analytics, cybersecurity, information technology, along with what we would expect, medical, engineering, and construction capabilities. They would have the same protections provided by USARA as the National Guard does. The Guard's command and control structure could present a model for the CRE management with state-based operations, a leadership hierarchy in each state, and a national leadership based in Washington, D.C., to assume command of these forces when federalized. As envisioned, the civilian enterprise reserve workforce gives the nation a trained workforce to address disasters large and small while delivering the essential capacity only when it's needed. In closing, FEMA now has activated for nearly 400 days. That's 5 times more than the 70-day record of 2017. The dedication of every one of our nation's first responders and FEMA employees is incomparable. They answer the call every single time America needs them. Congress needs to understand the pressures on FEMA, provide the necessary authorities and adequate resources for the agency's success. The nation deserves it. Thank you again for your time, and I'll be happy to answer any of the committee's questions.
Well, thank you, Mr. Nimish. We appreciate you being here today and for your testimony. Our final witness today is Ms. Elizabeth Zimmerman, former Associate Administrator for the Office of Response and Recovery within FEMA from 2014 to 2017. Ms. Zimmerman is an internationally recognized emergency manager with over 35 years of experience. And during her tenure at FEMA, Ms. Zimmerman held dual titles of Associate Administrator and Director of Disaster Operations, where she directed and coordinated programs and day-to-day operations within FEMA's response, recovery, logistics, and field operations directorates, including during major disaster and emergency activations. Welcome, Ms. Zimmerman. It's good to have you here with us. You may proceed with your 5-minute opening statement.
Great. Good morning, Chairman Peters, Ranking Member Portman, and the members of the committee. I thank you for the opportunity to speak with you today regarding the preparedness for COVID-19. COVID-19 pandemic is a maximum event that has stressed and challenged the United States health, social, and economic systems. This was a national emergency, not just a public health emergency. And for the first time in our nation's history, all 50 states, the District of Columbia, and the U.S. territories were under a state of emergency due to the consequences of COVID-19 being so severe, and they overwhelmed the state, local, tribal, and territorial governments. COVID-19 differs from other state and regional emergencies, and that every level of government was responding and focused on saving the lives of their residents while attempting to prevent the collapse of their economy and medical systems. All levels of government and the private sector were competing for the same scarce resources, such as medical personnel, PPE, and ventilators, while simultaneously attempting to prepare for the unknowns of the COVID-19 global pandemic. Several issues arose in the early days of COVID-19 that in hindsight could have been handled more effectively and efficiently. Our nation's emergency response and public health systems must learn from our recent experiences and mistakes by taking action now to update the plans, procedures, and better define the authorities to be ready for the next pandemic or any national emergency. In my written statement, I outlined 6 areas that I believe require further exploration for lessons learned, including the issues and recommendations for these changes. The 6 areas included the plans, lead federal agency, data management models and forecasting, commodities and logistics, the funding, and lastly, the workforce. I'm going to highlight a few of the issues and recommendations now. The plans. The National Response Framework is the overarching foundational framework for how we as a country respond to and coordinate disasters. The NRF is used by all levels of government to develop their plans. At the onset of the pandemic, the NRF, the Incident Command and Coordination System, were not acknowledged as being used. COVID-19 was being managed by siloed health system operations, not coordinated across the whole of government or with the private sector. In mid-March of 2020, when FEMA was named as the lead federal agency and brought the response under the NRF and organized the National Response Coordination Center, which is a system that everyone is trained, exercised, and accustomed to use. Recommendations going forward is that the NRF should be used for all events and incidents as the foundation for response operations in the U.S. Any agency can lead the coordination under the NRF. The second issue was designating a lead federal agency. Many times during national crisis, FEMA becomes the federal government's 911. COVID-19 is not the first time FEMA has been called upon to organize and/or lead events on behalf of another federal agency that is outside of FEMA's Stafford Act authority. H1N1, Ebola, Zika, Flint water crisis, the surge of sheltering the unaccompanied minor children all fall within HHS's mission and responsibility. FEMA was also involved in the EPA and U.S. Coast Guard's Deepwater Horizon response, the Department of Agriculture avian flu response, and HUD's long-term recovery and housing missions. While FEMA successfully took on these responses, if FEMA is going to be the 911 for the federal government, they must be given authority, staffing, and resources to ensure successful outcomes. Which leads to my third and final issue and recommendation that I'll mention this morning. Typically this time of year, FEMA's workforce has downtime amid responding to tornadoes, severe storms, and river flooding. However, this is not so in 2021. They have been working nonstop for over 15 months with a record number of staff deployed, second only to the 2017 hurricane season, and they're expected to top that number of deployed staff by early May. They are stretched very thin, and we know hurricane season is right around the corner. Recommendation is that if FEMA is going to be the go-to agency, their reservist program needs to be increased and professionalized, similar to the Military Reserve Corps, as Joe Nimick also mentioned earlier. Where individuals can take leave of absence from their job to serve their country and have the guarantee of returning to their job. I thank you for the opportunity to participate in today's hearing. As a lifetime emergency manager, it is important for us as a nation to make sure we include the whole community, government and non-government, private sector, in preparing for, mitigating against, responding to, and recovering from disasters. We need to be prepared now for the next pandemic. As COVID-19 demonstrated, it's not if, but when it will happen. I look forward to our discussion this morning, and I thank you for this opportunity.
Well, thank you, Ms. Zimmerman, for testimony. You're absolutely right. The men and women in FEMA do not have any downtime, and they certainly, we all appreciate their work. They're outstanding professionals, and we appreciate all that they do each and every day. Last month, former White House coronavirus response coordinator, Dr. Deborah Birx said, and I'm going to quote Dr. Birx here, quote, "There were about 100,000 deaths that came from the original surge. All of the rest of them, in my mind, could have been mitigated or decreased substantially," end of quote. That's certainly a pretty damning assessment in the wake of over a 500,000 deaths in the United States and increasing cases in Michigan right now and in states across the country. So my first question for you, Dr. Laurie, is that I'm not going to ask you to put any kind of number on it, but generally, would you agree with Dr. Birx's assessment?
Oh, absolutely, I would agree. And I think there have been a number of, modeling exercises that have suggested that 40+% of the deaths were avoidable. I want to remind us that it's not only the deaths, but it's people who have suffered long-term health consequences from COVID. It's people who have suffered long-term mental health consequences from COVID. It's their families, and obviously the consequences of the social and economic disruption. And I'd also just say, going forward, there's still a lot of opportunity to avoid death, not only with vaccination, but as you and Dr. Gerberding point out, by taking seriously now the surge we're seeing in cases and having people take the appropriate public health measures. We're still all in this.
Absolutely, we definitely are. Dr. Gerberding, would you agree with Dr. Laurie and Dr. Birx, again, without giving any numbers, but the general assessment of their statements?
Well, of course, I don't have the actual data or the modeling raw material, but I think it's common sense that if we'd been able to identify cases and isolate them and their contacts sooner, we would have seen a much slower startup to this problem, and we would have bought a lot more time than we were left to deal with once we recognized how widespread it had already become. So that clearly is a major issue. The reasons for it are complex. I've tried to understand them from the outside looking in. But I think, as I mentioned in my written testimony, there are some things we can do now to harden ourselves against a future that brings that particular problem to the bear, again, on the inability to respond initially. I will also say that this is a shared responsibility. CDC certainly made its share of missteps at the beginning. We also needed some regulatory support for expanding access to tests when they became available, and then a faster mechanism to bring the private sector that can really scale testing into the situation. So the solution is broad, but nevertheless, it was a very early and unfortunate problem.
Well, no question about that. And I want to focus now with you, Dr. Gerberding, on the 3-week period in late February to early March 2020, at the very beginning of what we saw with this pandemic. The number of COVID-19 cases in the U.S. increased by more than 1,000-fold, according to the CDC, a critical period, clearly, at the beginning of this pandemic. My question to you is, in your view, what factors led to that rapid rise in COVID-19 cases? And you've alluded to many of the different types of stuff, but if you could just focus in on that initial stage, which was just so critical, what steps could the federal government have taken to mitigate that spread right at the very outset during that 3-week period, late February to early March?
Yeah, I think it's tough. What we now know in retrospect, this is one of the most transmissible viruses we've ever had to deal with from a respiratory perspective. The fact that we've had ongoing coronavirus transmission, but essentially no flu transmission, tells you what the differential is in terms of their probability of spread. So it was a really tough challenge. And it was made a lot tougher by not being able to get in there early and really not just look at people with a travel history or those that we suspected were at high risk, but to understand very early in the course of things that asymptomatic transmission was happening at a rate, again, somewhat unprecedented in disease transmission. And we also, I think, really would have been much more assertive about doing sampling studies, population level sampling studies, where we really look for the hot spots based on what we know about previous settings where viruses are easily transmitted by the respiratory route, and accelerated the science of the transmission coefficient so that we would be able to better predict where to go to look for cases, even when testing wasn't widely available. So in a sense, this was a failure of imagination, a failure to appreciate that this wasn't going to be like SARS or MERS, where the efficiency of transmission from person to person was low. This was a disease that was spread like wildfire, and we responded as if it were sort of business as usual.
Dr. Laurie, I want to ask you a question related to those very initial stages as well, where we saw this acceleration of the spread of the virus. In your testimony, you identify multiple missteps in that initial response, and you specifically highlight, I want to quote what you specifically highlight. You say, quote, "All the authorities in the world cannot make up for the failure of leadership," end of quote. My question is what avoidable harm, in your view, flowed most directly from this failure of leadership as the initial pandemic response unfolded in January, February, and March of last year?
I think the avoidable harm started with the ability of the virus to spread like wildfire because we didn't acknowledge that it was going on, and we didn't take the steps to contain it. Either the public health kinds of measures that Dr. Gerberding talked about, the steps to ramp up things like the production of masks and PPE to protect healthcare workers and to protect the supply chain and others, and everything that's unfolded from there. If you think that the first 100,000 cases were maybe unavoidable or less, certainly we could have changed the trajectory of this and saved countless lives. So the failure to take all of the early actions, those that I mentioned and more, were really all avoidable and would have been much more avoidable had there been open and public acknowledgement of these risks. Even if we didn't know how bad it was our responsibility to prepare for the worst and to alert the public. The other really avoidable harm has been the politicization of this. And so the public has gotten really confused about who to believe, what to believe. And obviously people are still at odds with each other over a lot of aspects of this.
Right, thank you. Ranking Member Portman, you're recognized for your questions.
Great, thank you, Mr. Chairman, and thanks to all the witnesses. I want to start with the surveillance issue. We talked a lot this morning already about CDC, but what happened? Why didn't the CDC have the ability through the surveillance systems that we had in place to be able to detect this sooner? Seems to me they were relying on incomplete and outdated public health information, among other things, as I said in my opening. Some of you have talked today about the need for digital monitoring and that there were early warning signals that were not picked up. Dr. Gerberding, you focused on that. What sort of surveillance indicators was the CDC relying on at the outset of the pandemic to inform the public health response?
I think first and foremost was to take a look at what was going on globally. We had some information about the extent of spread in the Wuhan province. We had examples of pretty well documented spread from travelers into work settings in other parts of the world. I think the clues were there that this was a very transmissible infection, unlike SARS was in 2003. So that was the first thing, is to lean into the threat that exists. The second thing is testing. And, I think it was unlikely, even under the most rehearsed scenario, that we would have been able to immediately deploy a test for a brand new pathogen to 300 million people on short order. But we certainly could have utilized the tests that were available elsewhere in the world and had proven to be useful. And we could have worked much faster to bring the scale of testing up to speed with better cooperation and earlier engagement of the academic sector as well as the private sector. So the first thing that needs to happen is case detection, and then the isolation of the cases, the quarantine of their contacts. Now, that's a problem in the United States because finding contacts is basically shoe leather right now. It means you have to go out and more or less door to door track down the people who might have been exposed. And our workforce is way too thin to have been able to accomplish that once we had so many cases. It became almost impossible. I think a third piece of this is to use our epidemiologic common sense and recognize that with a respiratory pathogen, there are going to be certain congregate settings, confinement, high degrees of contact, where there is likely to be transmission. And to get into those settings first, do the testing and the epidemiologic assessment so we're ahead of the curve rather than waiting until cases were hospitalized and then find the hot spots in retrospect. So a lot of things are a combination of testing, workforce scarcity, and I think, again, just the inability up front to imagine how bad it was going to be.
Yeah, I'd like to dig a little deeper on the testing with you and Dr. Lurie and anybody else who wants to jump in, but backing up on surveillance for a moment, because it's not just about testing. As you indicate, it's also about the World Health Organization telling us what was going on, which they did not. China being more transparent, we know that. But what type of fixes do you think we need to make beyond additional funding, which I appreciate, and I appreciate the fact that you said the personnel are interesting, are needed. You mentioned, for instance, using technology better in your testimony and digitizing some of this. Just quickly, if you could, what could we do on the surveillance system in addition to testing to make it more effective?
Well, one really important point that I think is implied in your question is that this is a global challenge. Mm-hmm. And if we had really actualized the promise of the global health security agenda, we would have had much better insight into where this disease started and how fast it was spreading internationally. So we do need to come back to that global network of surveillance, not just a U.S. network. In the U.S., I agree with you on the digital tools and the application of our technology in new and exciting ways. But at the end of the day, it boils down to case detection as the first step.
Yeah. Well, let's talk about testing for a second. And again, anybody is free to jump in here. I'll tell you my frustration on testing was that CDC, and some of you have been involved in CDC over the years, and there's plenty of blame to go around here, but CDC had lousy tests. And, in Ohio, we were given a bunch of CDC tests, and that was the only place to get tests, as we understood it. And, they didn't work. There were defects in them. And it prevented our labs from being able to validate the tests, rendering them basically useless. I don't know if you know this, but in Ohio, the result of this was that some of the private sector jumped in, and particularly the Cleveland Clinic developed its own test. And give you some dates here. We got our first, our botch tests from CDC on February 7th. We didn't get a working test kit from CDC until March 5th. So virtually a month went by, and talk about, a waste and an opportunity to save lives. And the Cleveland Clinic developed their own test and put it online on March 13th. That test I took, by the way, early on. But why were we so reliant on CDC? Shouldn't we have been encouraging the private sector to be involved all along? And again, Dr. Lurie, to jump in here, how did the legal and regulatory landscape at the time help or hinder institutions like the clinic, to use them as an example? But there are groups all over the country doing this, from developing their own tests. Could you respond to that, Dr. Lurie?
Yeah, sure. So what I would say is early on, when it was clear very early on that we're going to need an awful lot of tests, and tests were developed around the world, as Dr. Gerberding said, some of them work quite well and we could have used them. And when CDC was struggling with its test, or even before, BARDA should have exercised its authorities and gotten in early on to stimulate the development of diagnostic tests across the private sector and in the academic sector, so that you would have had a variety of tests earlier. There was no entity that took responsibility for pulling samples together to validate diagnostic tests. And so all of the test developers really struggled. And so FDA gave an awful lot of them a pass and said, well, you're not going to need an EUA. We're going to go ahead and assume things, assume a number of things. And then it turned out that we had diagnostic tests that didn't perform well at all and had to come back off the market. So the failure to get in early, ask the private sector to develop tests, agree to work with them, provide the support that they would need for validation, and then be able to scale, I think were really significant failures, stemming from the failure to want to recognize that this was happening. The authorities were clearly there.
We've got to learn from that clearly. And, it just amazes me that we were so well prepared in terms of our diagnostics. My time is coming to an end. Admiral Nimich, I'd planned to ask you some questions about the Benz Commission. I appreciate the work on that. Senator Hassan was involved, who's on the panel today, Senator Cassidy, but we really have appreciated that, and we're using some of your work. I guess the planning and the exercises, were not adequate in this case. And one question I want to leave with you as I end my time is FEMA the right organization to head up something like this? There's a difference of opinion as whether it should have been HHS or FEMA, and was FEMA the right entity? So I'll sort of leave that question out there, hoping somebody else follows up on it who has more time available. And thank you, Mr. Chairman.
Well, thank you, Ranking Member Portman. Senator Hassan, you are recognized for your opening or for your questions.
Thank you, Chairman Peters, and to Ranking Member Portman, thank you as well for the nonpartisan approach that you have taken to convening this hearing. To our witnesses, thank you for being here today, but also thank you for your service. I do want to start with a question to Mr. Nimich, and I'll ask you the question, and then if you want to fold into your answer a little bit about your thoughts to Senator Portman's question, that's fine too. It was really a pleasure, Mr. Nimich, working with you on the Benz Commission on the National Response Enterprise. In your testimony, you discussed one of the topics addressed by the Commission, which is the importance of exercising emergency plans. A report from the 2019 Crimson Contingent exercise found that with regard to the crisis in that exercise, there was, quote, confusion between HHS, FEMA, and the Department of Homeland Security on which federal agency would take lead in the crisis. Unfortunately, we witnessed this very same confusion between the role of HHS and FEMA during the COVID-19 pandemic. And this confusion certainly contributed to an overall lack of coordinated national response. So first, Mr. Nimich, do you support updating the Stafford Act to clarify FEMA's response role to include pandemics?
So I think the two questions are highly related, and the question really comes support and supporting. I use an awful lot of Department of Defense concepts because response to whether it's a Department of Defense issue or a domestic issue, responding is pretty standard. So I don't think it is a requirement that we identify early on who is the lead agency and who is supporting them. You can add into the Stafford Act for pandemic, for cybersecurity, cyber events, and that would allow FEMA to be funded to do the work that's necessary. but it doesn't have to put FEMA in the leadership role. FEMA coordinates, and they take the rest of the whole of government and bring it to the event. So I do think that FEMA has a role to play in a pandemic. It has a role to play in almost any type of a national crisis, but it doesn't necessarily have to be in the lead, but it has to be defined early. The national or the pandemic playbook that the NSC had in their hands had triggers of when certain things should happen. And those triggers rely on the data, whether it comes from CDC or someone else. You have to validate those, you have to exercise that, and make sure each administration is comfortable that the data they're receiving, when the trigger is set, that they know who they're going to put in charge.
Thank you. I want to follow up on that a little bit, just in terms of the exercise issue as well, because regarding the 29 exercise that identified this potential problem, how do we ensure that the federal government is actually implementing improvements on what's learned from these emergency exercises?
I think that's a great question. And the challenge always is, where do the resources and the policy changes being made in order to address the problems you found in an exercise? All too often, we say that was a great exercise. We plan for what we can do and what not necessarily what will be done. I ran the SUNS exercise for a spill of national significance in January and February of 2010. We did a great job. We identified certain problems, but we planned on what we could do. A ship running aground with 600 million gallons of oil. We learned in April of that year that you can have an uncontained spill, all of with the New Horizon. So I do believe it is planning for, as Dr. Laurie said, sometimes the unimaginable, and then exercising those plans.
And then making sure there's communication about what you learned.
That's right, the policy and the funding.
Thank you. To Dr. Gerberding, as former CDC director, you understand the importance of communicating effectively with the American public. As you know, there are some who are concerned that vaccine hesitancy may begin to impact our vaccine administration efforts in the coming weeks. What steps can we take now to improve public confidence in existing COVID-19 vaccines so that we can vaccinate at a rate that mitigates the threat of emerging variants? And how do we communicate the importance of vaccination as critical steps towards reaching herd immunity?
Thank you so much for bringing this up, because as I'm sure you know, at baseline, we deal with a severe crisis in vaccine confidence in the United States and elsewhere. So this pandemic has brought that to the forefront in every way. The good news is the efforts so far, which particularly emphasize reaching into the communities and constituencies that have the greatest degree of concern and bringing not just scientific information, facts and figures, but the messages and the engagement of people they trust. Sometimes at the community level, that's a pastor or a barber, or it may be the frontline primary care provider. But we've got to build out a network of people who have the facts, but also have the trust of the community. And, you know, in many communities, the government is not the most trusted part of the equation, nor are the manufacturers of vaccines. So this is a matter of all of us affecting, you know, in my company at Merck, we're working hard to build confidence among our own employees. We're working with the World Economic Forum to help employers understand how they can inform their employees and help them make the right choice about vaccination. But I think it's an uphill battle, and we are pleased with the support and the supplement to help the CDC lead that communication effort. But at the same time, we have a long way to go before we really achieve herd immunity on the basis of vaccination because of the reluctance of so many people. And whenever there's a safety concern, people really struggle to put the very high risk of COVID into the context of low but real potential risk from immunization. It seems like the risk of the vaccine looms so large in your mind, and yet the risk of COVID is deadly to far too many people. And we've got to help folks recognize that this is a really important tool, especially if we use it right now. So I'd love to talk with you offline more about this, because I think there's much more we can and should do.
Well, I thank you because you really answered my next question too about how do we get to communities where the skepticism is the greatest and that have traditionally and historically faced the biggest challenges in access too. So I'll look forward to that. I thank you so much too for pointing out not only the risk of death from COVID, but also the long-term risks for long-haul COVID patients compared with the low risks of vaccine. Thank you, Mr. Chairman. And lastly, I'll just say to Mr. Nimick, you can expect a follow-up question from us on how do we make sure that we have the kind of surge capacity we need as we move forward with FEMA having more and more responsibility as that kind of lead emergency agency. Thanks again for the hearing.
Well, thank you, Senator Hassan. Senator Hawley, you're recognized for your questions.
Thank you, Mr. Chairman. Thanks to the witnesses for being here. Ms. Zimmerman, I'd like to start with you, if we could, and discuss the supply chain issue. I noticed in your written testimony that your recommendations about logistics and just-in-time manufacturing, saying that they don't really work in your experience and observation when we're in the midst of a global event like the one we've just gone through. I certainly agree with that, and I'm wondering if you could just elaborate about your experiences at FEMA. What demonstrated to you that the just-in-time model is insufficient for a major crisis like the one that we've just gone through?
Great. Thank you, Senator. Right. The just-in-time, when we're working, especially in the medical supply chain, medical supply, the hospitals, what we've noticed is that they don't have supply on hand for much more than a few days. They require the just-in-time to replenish. They have their contracts so that they can get the supplies they need for their day-to-day operations come in, and they don't have to also have a huge warehouse to store them in. They rely on the private sector for doing that. So being able to get those commodities when you need them in the extreme amounts that we did during COVID in the early days and before manufacturing can get pulled up, it made it very critical. And that's when we saw that, there weren't supplies within the United States. We needed to go elsewhere. We needed to go to other countries. And when it was set up to bring in the commodities from other places. So the just-in-time can work fine in smaller events, just like the FEMA distribution centers that they have across the country. But that stockpile of the water and the blankets and the things that we need to protect lives and get things stabilized during normal natural disasters that FEMA works in. But when it really comes to a global event like this, just-in-time doesn't work when we don't have manufacturing ready to go to bring in those commodities at the numbers that were needed.
Well, I have been an advocate of reshoring our critical supply chains and introduced legislation to do that. And I think it's absolutely something that we have got to pursue and make a top priority. But you and I both know that process of onshoring will take time, and it's vital we do it. But that is a medium to long-term project that we need to start now. But in the short term, do you have any recommendations about how we can reduce our reliance on the just-in-time model and improve our resiliency in the midst of a major crisis? Well, what can we do immediately that will have short-term implications or effects?
So I think immediately we need to look at what supplies are in hand. We look at the strategic national stockpile when it comes to COVID or any other pandemic and medical issue. Looking at those types of things, we always try to plan for those maximum events so that we have things. So really looking what we have there. Looking at when they use the Defense Production Act to change over manufacturing from cars to ventilators and that. So how do we really do that? But what are those key critical things that we need? And I think after the last year, we saw the PPE and the supplies that were needed by the medical first responders. So we need to make sure that we have a way of getting those within this country and how we stand up those abilities immediately when we see something happening. So I think this is an opportunity right now. We're still in the midst of the COVID-19. And where are we, now with getting commodities in and how we've resourced and been able to get things, even for the American people, the masks that people are wearing, the other supplies and things that we need. So looking at where we are today, and we need to accept where we are today, but what are those other things that we might need going forward? And we need to be prepared to supply those.
Yeah, very good. Thank you. Mr. Nimitz, let me just give you a chance to weigh in here, given your experience at FEMA. Do you have view on the supply chain question, whether that's stockpiling, as Ms. Zimmerman just said, stockpiling commodities or ramping up production on a temporary basis, or something different?
Not dramatically different, Senator, but you could tell from my body language, yes, I have some pretty strong opinions on the ability to move from just in time. And the national stockpile is a good thing, but it's not the only thing we can do. And we can, while we're bringing ashore the capacity and being able to understand the Defense Production Act and how we would utilize that in a future capability, we can incentivize hospitals and local medical capability to go over their efficient level, to be able to bring in and actually rotate the stock of medical equipment so that if it's in the national stockpile, it doesn't go stale on the shelf and then have to be replaced at a larger cost. So I think we could look at ways of incentivizing hospitals and medical facilities to keep 110% of what their daily requirements are. And that 10%, if we incentivized it, the federal government or the states could reallocate to other areas. You've now distributed your stockpile across the nation, and it's closer to where you're going to need it whenever you need it.
Oh, that's good. That's very interesting. Let me ask you about the Supply Chain Stabilization Task Force led jointly by DOD and FEMA, which the last administration helped set up, or did set up to help coordinate and maximize the procurement of things like PPE. How well do you think that worked? I mean, what should we learn from that experience?
Like any task force, it took time to establish itself and understand each other's roles. When you, again, look at the Department of Defense, they understand the national defense industrial base. They know where the capabilities are. We don't try to create a comparable industrial base that we understand and we maintain, and it goes to your bringing back to shore the infrastructure to be able to do this. So I think the task force performed admirably once it had been established and they understood each other's roles. But you have to have, like DOD does, the infrastructure in place to understand how you're going to do this before an event. Creating it during the event reduces that time to perform.
Very good.
I just try to jump in here for a minute, if I could, with one additional suggestion. And we experienced both shortages in H1N1 and Ebola, and found that in different places in the private sector and in government, there were actually large supplies that were double and triple ordered, but the government didn't necessarily have the mechanism to go to all the manufacturers and distributors and ask where it was in the system. So clarifying authorities for it to be able to do that in an emergency, you can see where it is and redistribute it quickly, I think would be very, very helpful.
That is helpful. Thank you. I see my time has expired. I'll have a few more questions, Dr. Gerberding, for you, and Dr. Lurie, for you as well, for the record. But thank you, Mr. Chairman.
Thank you, Senator Hawley. Senator Rosen, you are recognized for your questions.
Thank you, Chair Peters and Ranking Member Portman. So it's a really important hearing, and I appreciate all the witnesses for everything you've done and for being here today. But I want to talk a little bit about data tracking and early pandemic response. And so, as we know, the pandemic dominated American life last year, and of course into this year. Our focus has rightly remained on tackling the immediate challenges before us. We have to work to save lives and livelihoods. However, I do think there were missed opportunities to get a better picture of the pandemic, which is critical to understanding how to protect people dealing with the long-term effects of COVID, making sure we're not leaving anybody behind. So moving forward, I believe we need to be sure we have a comprehensive making comprehensive understanding a priority while still doing research efficiently so that data collection doesn't delay us getting help to those who need it. It's not so cumbersome because a novel virus like COVID-19, it's critical we have full understanding of the impacts. Only true data collection is going to tell you that. So last year, I introduced a bipartisan Ensuring Understanding of COVID-19 to Protect Public Health Act. I want to make sure we get started on those comprehensive long-term studies with regular reporting right away so that researchers and clinicians can have the latest information. Some of the studies have started, but of course there's significant gaps. I hope all my colleagues will join me, but Dr. Gerberding, can you please discuss some of the remaining gaps in research we have, especially now that we're seeing the long haulers? People are in it for the long term, where they seem fine and things are popping back up. And how does the virus seem to be impacting patients differently, especially, so we need to do research on this.
Boy, we have a lot to learn. Just start with the medical dimensions of the infection. You're absolutely right. We don't really understand the actual pathogenesis or the mechanism by which this virus causes such a myriad constellation of diseases. You know, everything from no symptoms all the way to devastating multi-organ system failure. Some of that is perhaps related to viral load. Some of it is genetic, but there's much to be learned there, just at a very, very basic medical level. But in addition, the syndrome of the post-infectious phase of COVID, which is increasingly recognized as a broad constellation of findings with a pretty durable impact on people, not just their physical health, but their mental health and their ability to function. We've got to understand this post-infectious phase of illness. But I think there are also many things that we need to learn about the basic epidemiology. And again, that's where data systems can be our best friend, because we may be able to probe things from existing data or more rapidly get our hands on data that are evolving through our health systems and our public health systems to be able to draw connections and see patterns that we can't currently recognize without the use of artificial intelligence or machine learning type tools. So the list of what we need to know is long. I think right now everyone is kind of focused on the most critical things in the context of care of patients and vaccination, but we are going to be with this coronavirus for a long time.
Well, I agree with you. The list is long, so we need a vast amount of information. We need it quickly. And so I've heard from some of caregivers up and down my state, especially in smaller, more rural areas. They're hesitating on some things because they don't know if they have the capacity to comply with the various reporting systems. So how do you think we need to simplify the process so that everybody giving vaccinations and treatments in our community health centers and our smaller hospitals, that we have the interoperability and the ease of reporting so we can get this vast amount of data to us quickly? So Dr. Lurie and Ms. Zimmerman, maybe you might respond to this collecting of data and the interoperability to give the doctors the tools they need going forward, give all of us really.
Sure. Well, I'd say a couple of things. First of all, it got going late, but there are now mechanisms through something called Project Echo to pull doctors together every week for sort of peer-to-peer learning about best practices and how to treat one another. And I would encourage all kinds of healthcare providers to take advantage of that. But make no mistake, our data systems are really, really siloed. You're right, they're not interoperable. And in fact, there are vast amounts of data out there that go unanalyzed because, we don't have the tools to do it and we don't have the workforce to do it. Going forward, I think we could ask ourselves very fairly now, what needs to be done by humans? Or could you have sort of early aberrant signals picked up now by machine learning, by artificial intelligence and others, so we could put the highly trained human capacity where it needs to go and not miss signals and be able to aggregate data much more quickly. On the data end, we've made such great progress from the perspective of integrating it or health care and public health data together into the way we understand the disease and the way we make decisions. We have a really long way to go and huge opportunity there to do better.
Thank you. Ms. Zimmerman, what do you think we might be able to do to help improve this interoperability between, I guess, I want to say partners, whether they're healthcare, FEMA, community partners, mobile clinics, you name it, there's hospitals, all of our system. Do you have suggestions for us?
Yeah. Yes, thank you, Senator. Exactly, because we start chasing the data, and in the beginning of COVID-19, everybody was chasing all sorts of data. There was no set parameters of what was needed to make decisions. And in the beginning, you're making it with limited data, and that's what emergency managers do. They go forth and push. But I think we have a great opportunity right now to look at what data provided us the best information in order to make those decisions. What are those immediate decisions you need to make at the onset of a pandemic or any type of major medical thing that's impacting the nation? So I think it's looking at what were the things that gave us the outcomes. So to me, you need to look at the outcomes and then what is the data needed to get that, and to be able to put the smart people in the room to determine what is needed in that regards, I think is very key right now, because otherwise we, with all of the technology and everything that's out there, we go chasing a lot of data points that don't give us an outcome that matters. And we need to look at what are those outcomes that are going to matter to shortening the time period for all of this that we've been through.
Well, thank you. As a former analyst, I couldn't agree more that the data tells a story if you figure out how you need to listen to it. And we really need to understand the lessons we've learned that we can use, not just for going forward in this pandemic, but God forbid we have another or the next public health emergency. So this should be able to guide us. Thank you. I'll submit the rest of the questions for the record. Thank you.
Well, thank you, Senator Rosen. Senator Johnson, you are recognized for your questions.
Thank you, Mr. Chairman. Dr. Gerberding, first of all, welcome back to the committee. I remember you testifying before our committee on February 12th on many of these same issues. I'm sure we talked about testing. I want to talk a little bit about that, but I know it was in that hearing that I found out, because FDA Commissioner Gottlieb also testified about our lack of API in terms of pharmaceutical ingredients. As I further investigated that, I found out there's something even before API, which is what they call intermediate. It was an odd name because it's really the precursor chemicals. It sounds like most of those precursor chemicals, because of the dirty manufacturing process, occurs in China. Is that accurate?
I think it depends on what product you're talking about, but the global supply chain that is the raw materials, the intermediates, and the API certainly includes China, India, and many other locations around the world.
But if we really want security in terms of our pharmaceutical industry, we really need to get not only API back in the U.S., but